I'll try and catch up some time. Actually, you've heard about many of the developments in surgical and medical care, and one of the really fun things about working in this area is that there are so many changes. It's very dynamic. But I think Professor Heaton said earlier, I think much of the revolutions have already happened, and I think the developments are now quite evolutionary. And it's actually quite hard to say because these are happening on a day-to-day basis. You say, well, this is what we do. And sometimes, you know, it's quite hard to say, well, when did this development start? I'm just going to pick out two things. I'm just conscious of time, and these are at fairly random events. I won't make it any quicker if I can't put the slides on. Thank you. You do need surgeons as well, you know, I think. One of the things I wanted to talk about, really very recent developments in hepatitis. Two forms of chronic hepatitis that are of importance, hepatitis B and hepatitis C. Terrible diseases. If you get them, it can be really tricky to get rid of them. With hepatitis B, sadly the United Kingdom has not yet come round to universal vaccination, whereas almost all the rest of Europe has. So that'll be one fight that we need to come back to. But hepatitis C is a particularly troublesome disease, a rare disease in children, but children who get it find it's very difficult to get rid of it, and it has long-term implications for them, and it does increase the risk of developing cancer in later life. And this is the horrible little protein. You know, no attractive features about it at all, but overall, on its surface, the virus does have some proteins which may turn out to be his Achilles heel as we find different ways to attack the virus. We measure this now actively in the bloodstream. We can do, Paddy's talked about these tests of PCR, very accurate tests for measuring the virus, and we know there are at least 6 different types of the virus, and that's quite important for the treatment. So we can individualize treatment depending on which of the genotypes you're unlucky enough to get. With children, the treatment is very important because some of these have traditionally involved injective treatment with a drug called interferon, and it is very difficult to tolerate. Interferon is produced by the body when you get the flu, so some of the side effects of interferon are having a flu-like illness. And this is a very, very difficult thing to do, and it has to be given by injection. So preparing families and children for this treatment is a huge effort, and I think I'm amazingly successful that the nurses and the families can actually convince children that it's important to take these drugs. So it's the interferon, very important, but you know, historically this didn't look very good. The first interferon that came out had to be given 3 times a week. So up to 3 times a week you felt like you had the flu by injection. Things started to get a little better as we added in another drug called ribavirin, and you're up to maybe clearing 60%. Big development then, both from the making it effective, was the introduction of pegylated interferon. So it made the interferon last longer, and you only had to get the injection once a week or so. And then you're getting up to responses with some of the genotypes of 100%. And this was really very exciting. This looked very good indeed. And so that we can actually change the treatment. With the viruses that get better, you can stick to 6 months of interferon and ribavirin treatment. For this more troublesome type of hepatitis C, the type 1, you needed to go for at least a year's treatment. But you could look in children with up to 90% treatment. But a huge impact for children and their families really with doing that. And then a new set of drugs come along. These protease inhibitors. And these are now not pediatric data, but they're adult data because these have not been tried on children yet. And traditionally, children have always responded better than adults to hepatitis treatment. So you can see that with the traditional treatment was 40, 50, for this group 20%, and a whole increase of approximately 30% better chance of these new drugs improving their efficacy. So it looked like things were getting better and better, but these were add-on treatments to interferon. So you still had to take the interferon. And now the most exciting one are really these group of drugs, which are orally active antiviral drugs, and they actually directly affect the virus. And this is some work that's only yet been published in pilot work, but this was a combination of 2 drugs which were taken orally for 12 weeks. It almost sounds as a little fantasy, and almost all people clear the virus, and you can see this is the important thing, the sustained viral response. So 12 weeks after stopping the treatment, you can expect to have 90+%. And this is not in people who've never been treated before. These are adults who don't respond so well, who've also failed to respond to interferon variant. So now, what we can really hope to that in the future, there's a good expectation that our children who are affected with hepatitis C will be able to take oral treatment for 3 months and clear the virus. And that's a huge change in practice. Now, that isn't there yet. This has to be evaluated for safety and efficacy in children, but this is very, very exciting, taking things forward. The second thing I'll just mention, and then I'll finish on this, really is, this is something that I'm less happy about, and this is something that is a development that we're taking on. Sadly, we and our children are all getting fatter, and this is a slide of a normal liver biopsy, and this is a slide for somebody who has fatty liver disease, who's 7 years of age. And this is not how it should be, and I think as a society, like hepatitis B vaccination, we have to prevent obesity. But sadly, we failed in that before, and we know that children become obese, and sadly, obese children become obese adults and develop all the complications of this. We know that our medical efforts to try to get people to lose weight are not very effective. So, and we know that surgery, there are surgical approaches which are very, very effective indeed, but they're generally non-reversible. It requires an operation where part of your bowel needs to be resected or moved to another part. So it isn't just an easy reversible operation. So because children are still growing, in older children, we wanted to explore something that was reversible. And this is an endoscopic treatment. This is the stomach here, and this is a balloon that's inflated in the stomach. And the hope is that the balloon will stay inflated, and hey, I think I'm full all the time. That's what we hope. And in adults, this has looked to be very effective with people losing anything from 12 to 30 kilos. So it can be very, very effective. Now, you have to be terribly big to lose 30 kilos, you know, I have to say other things. This is what it actually looks like. It comes as the balloon isn't blowing up as part of what's essentially a big nasogastric tube, and then it's passed down while the children or while the teenagers are asleep. It can be pasted into their stomach here, and it's still connected at this end, and we just fill this with saline, and it gradually gets bigger until it's fully inflated in the stomach, and then we remove the endoscope. You can see that this is coming back into the gullet, this stays in the stomach, and this is removed then after 6 months. And so far we've done this in 3 children, and it's been associated with weight loss of approximately 10 kilos. Now, what I hope is, I have a dreams, is that we just do this for the next 5 years, because I hope that as a society we will work hard on preventing obesity happening so that we don't have to do crazy things. I think I'm conscious of time, I'll stick to that really. I think that's enough.